Acute myeloid leukemia is a fast-evolving disease, and one where every decision counts. What has changed in the past 10 years is that we now have the tools to make those decisions much more precisely than before. So, on the occasion of AML World Day, I have the pleasure of speaking with Professor Maria Teresa Voso, Professor of Hematology at Tor Vergata University in Rome, Italy, about what AML actually is, how molecular testing has changed treatment decisions, and also what patients and their families go through. Professor Voso, thank you so much for being here.
Thank you for the opportunity.
Let's start at the very beginning. When we talk about AML, what does it actually mean and what happens inside the body?
Acute myeloid leukemia, AML, is a type of blood cancer. It's a type of leukemia which originates from the bone marrow. And the bone marrow is the site where, under normal conditions, all blood components gradually mature and become red blood cells, platelets, and leukocytes. In AML, genetic changes block the maturation process, and this results into the accumulation of abnormal immature cells called blasts, which multiply uncontrollably, crowd out healthy cells. And this process goes on very quickly, and that's why it is called acute myeloid leukemia.
And how common is AML?
Well, actually, AML is a very rare disease. It accounts for about 1% of all new cancer cases every year. And if you would like to make a comparison, we can say it's several hundred times less frequent than breast cancer, for instance.
So it's a very rare condition. What would explain that someone would develop such conditions? Are there risk factors that you have identified?
AML is mostly a disease of elderly individuals, and the median age at AML onset is 68 years. It is, again, the result of a process of acquired genetic changes in immature bone marrow cells, and it may evolve from a previous myelodysplastic syndrome or from a previous myeloproliferative neoplasm, which are chronic conditions.
And have you identified other external factors and triggers, such as environmental or perhaps former medical treatments and things like that?
Yes, other risk factors are environmental factors, including, for instance, pesticides or benzenes, but also previous treatment for primary solid tumor or another hematologic neoplasm, including, for instance, chemotherapy or radiotherapy. These forms are called therapy-related AML, and they onset several years after exposures to specific chemotherapy agents, including, for instance, alkylating agents, topoisomerase II inhibitors, or also radiotherapy. Genetic predisposition also plays a role in about 10% of the cases. This has been a new knowledge from, in the last 5 to 10 years. Familial cases have been identified in about 10% of cases.
What makes AML particularly challenging is that the symptoms are very unspecific. So what should people be paying attention to? And also, what should a general practitioner not dismiss too soon?
There are some specific symptoms related to the shortage of blood cells, including red blood cells, and this is usually pain, fatigue, shortness of breath, paleness, and this is due to anemia. But there are also symptoms related to the shortage of white blood cells, in particular neutrophils, which lead to more frequent infections and fever. When platelets are affected, so reduced platelet counts lead to easy bruising, unusual bleeding, and petechia. There are also more generic symptoms, as you mentioned, and these include fever, weight loss, swollen gums, and a generic feeling of unwell. So when patients experience non-specific symptoms, they usually visit a healthcare professional. And also with non-specific symptoms, the healthcare professional will prescribe a complete blood tests which could reveal abnormalities. And these may include increased or decreased white blood cell counts, would include decreased red blood cells and decreased platelets, but also the presence of abnormal immature cells in the peripheral blood. And this is due to the examination of peripheral blood smears under the microscopes, which may identify leukemic blasts.
And if the blood test raises a suspicion, what are the next steps to confirm the diagnosis?
Yeah, the next step is usually a hematology consultation, and the hematologist will perform a bone marrow biopsy or a bone marrow aspirate. The goal of these tests is to identify abnormal immature cells in the bone marrow. And this, to perform an AML diagnosis, need to be over 20% of bone marrow cells. And it also helps to provide the samples to perform additional testing, which is necessary for AML diagnosis.
And if I understand correctly, AML is not a single disease. There are different types, is it not?
Yes, true. AML includes a lot of subtypes, which are usually identified according to also to the new classification, according to the genetic lesion or to the molecular lesion. And the genetic profile of the leukemias plays a role in the classification, but also in the prognostication to indicate what is the type of treatment that we need to use to ensure the highest probability of cure and what the overall prognosis might be.
So molecular testing will play a very important role, although not the only one playing an important role, as we will discuss. But can you explain just how critical this molecular testing is for our audience?
Yes, molecular testing, in addition to karyotype examination, is very, very important because in addition to playing a role in identifying mutations associated with improved or decreased prognosis, it also identifies molecular targets which can be targeted by specific drugs.
And can you walk us through what this test actually involves so we have a clear representation? And what are clinicians actually looking for?
When we do a bone marrow examination, in addition to looking at the bone marrow smear and counting blasts, we can perform immunophenotype. This helps to analyze proteins on the surface of leukemic blasts and distinguish AML from other types of leukemia, such as, for instance, ALL. We also can do cytogenetic analysis since AML is associated with alterations in the karyotype, so structural abnormalities or rearrangements. And using the same bone marrow blood, we can detect gene mutations, and the most common are NPM1, FLT3, IDH1 and ADH2 in AML, and these are used for risk stratification, but also as potential therapy targets.
So it's a very comprehensive set of exams, if I understand correctly.
Yes, this has been changing in the last years, where maybe 30 years ago, a bone marrow examination was enough. Nowadays, we need to do all these tests, immunophenotype, cytogenetics, and molecular biology, to personalize treatment strategy. And indeed, thanks to this, we have significantly improved the patient's outcome. But not only that, this defines a disease profile, which then must be integrated with the patient's profile.
You just mentioned the patient's profile. Can you explain what that means?
As we said before, AML is a disease of elderly individuals. So when we are evaluating the treatment options for the patients, we need also to take into account additional medical conditions such as cardiovascular disease, diabetes, hypertension, or chronic lung disorders. And these may all impact the tolerance to intensive therapy.
And there are many factors that can create this variability between one individual and another. How do you assess whether someone can tolerate these intensive treatments that you're mentioning?
Yeah, the whole procedure is named assessment of patient fitness. And since, as you mentioned, not patients of similar age may have different comorbidities or other factors which may affect treatment tolerance. So we can do some general evaluations, and this includes the performance status, which goes from 0, fully functional, to 4, which is completely bedbound. But we also do some eyeball testing based on our experience, but this is not enough. We really need to do some objective testing to evaluate organ function.
Now, if we look at it from the patient perspective, can you walk us through what the patient actually goes through? And specifically, what are the main phases of treatment?
If we decide that a patient is fit for intensive chemotherapy, this means induction treatment. This is a chemotherapy cycle with the target of achieving complete remission. That means elimination of blasts from the bone marrow and a complete recovery of blood counts. Once the result is achieved with induction, we do one or more cycles of consolidation, and this may be also followed by allogeneic stem cell transplantation, which is part of the consolidation treatment.
And if that works, so if we reach remission, what happens next?
As mentioned, we can do a consolidation treatment, and depending also on the genetic characteristic of the disease, which define high-risk disease, and that means disease at high risk of relapse, we may decide for allogenic stem cell transplantation. And some diseases some patients are candidate to allogenic stem cell transplantation from diagnosis on because of the biology of the disease. If the biology is favorable, chemotherapy may lead to cure.
Remission is obviously the goal, but does that mean that the disease is necessarily gone?
Unfortunately not. In many cases, the disease may relapse, and so a long-term follow-up is required with regular monitoring after remission. What we do is we use techniques to early detect relapse. If we detect relapse at low level, this means faster therapeutic intervention and also a higher probability of cure.
There's one term that we keep on hearing. It's measurable residual disease. Can you explain what that is and what it means in practice for patients?
Measurable residual disease is the presence of small number of leukemic cells in the peripheral blood or in the bone marrow. And these residual cells may be the causes of subsequent relapse. So we use techniques such as flow cytometry or molecular biology to identify these cells. And the positivity of MRD has significant prognostic implications. So MRD negative patients are those where the disease is not detectable and are those with the highest probability of cure.
Beyond the medical monitoring, what about the impact on patients' everyday lives after the treatment?
Of course, there is an impact, and long-term follow-up is required to manage treatment-related complications, which can also occur late after treatment stop. However, behind physical health, also psychological and social aspects are very important including anxiety related to fear of relapse, difficulty returning to work, and challenges reintegrated into daily life. So regular medical visits are important to help reassure the patients and also give access to supported resources. And among these, patient associations do really play a very important role because they inform the patients on also, for instance, legal aspects related to the disease and the time after the disease, but also emotional and psychological support is given. And those patient association has safe spaces where patients and caregivers also can share experiences and feel understood.
Well, that was exactly my upcoming point about resources and caregivers, because they play such a crucial role being there for the patient and helping the patient. What role exactly do they play? And do you think we're doing enough to support them?
They really play a central and indispensable role. They are usually other family members or close friends, and they give practical assistance, help manage medication, they give emotional reassurance, but they're also important during prolonged hospital stays, supporting the patient during the experience of side effects of the treatment. However, caregiving is also itself physically and emotionally stressful, and it can also implicate financial strain for the caregivers. So supporting caregivers and not only patients ensures well-being for both parts.
Of course. And there's also growing recognition of the needs and opinions of those caregivers that we didn't use to integrate beforehand. What is your opinion, or even your experience, if you have some, integrating that caregiver's voice into research and clinical practice?
Yes, I think this is one of the breakthroughs of the last years. And clinical trials are now really involving patient and caregivers, and they also measure the impact of illness on the whole family, not just patients. And a burnt-out caregiver may give a weaker support to the patient and may affect treatment outcomes. So giving caregivers a formal voice helps to identify their needs and create tailored support. Patients and caregiver well-being are linked. You can't fully care for a patient if you don't care of the caregiver.
Professor Voso, thank you so much.
Thank you for this opportunity and for the opportunity to raise awareness on AML on this very special day.
As you have seen, when it comes to AML, treatments have evolved so much in the past 10 years. But there is one message that I will take away from this conversation that is really important, is that when it comes to a diagnosis, there's a whole group of people that are impacted. The patient, of course, but also the caregivers, the family and the friends, and we should take care of them as well. Thank you so much for watching this video.